So, as we think about innovation at community health centers, we're joined by Sonya Bruton and then also Nancy Johnson. So, I think maybe to start out, because there's such a wide variety of community health centers across the country, it would be helpful just to provide maybe a bit of a level set, or maybe paint the picture of your community health center right now and where you sit in the patient population. So, Sonya, you want to start?
Sure, I'd be happy to begin. My federally qualified health center sits not far from here, down the road in Silver Spring, Maryland, is where we're headquartered, and we serve 2 counties in Maryland, Montgomery and Prince George's counties, 2 very different counties. We see about 78,400 patients a year through about 105 or so thousand visits, and we offer medical, dental, behavioral health. We also have the WIC program, and we do refugee health services in a pretty large way. We are growing, as many health centers are, as the needs continue to expand.
Hi, everybody. It's nice to be here today. I come from Tucson, Arizona, so I traveled a little bit further than Sonya today, but I'm the CEO at El Rio Santa Cruz Neighborhood Health Center. We were founded in 1970, so we're one of the older health centers in the nation. We take care of about 125,000 unique people in the urban area of Tucson, about 60 miles from the border of Mexico. We have about 250 primary care providers taking care of family medicine, pediatrics, internal medicine, dental care, behavioral health, both on the primary care side and the care of a lot of SMI patients. And as you all know, in community health centers, it's that one-stop shopping model. So our patients come in, they have all the disciplines available there for care, but also laboratory, filling all their scripts, imaging services, eligibility assistance with Medicare and Medicaid. And then I think it's noteworthy to identify the payer mix of our population. About 51% of our patients are on Medicaid. About 20% of our patients are commercially insured, 13% uninsured, the remainder falling into that Medicare space. So, in our urban area, we represent about 10% of the primary care delivered to our community. Thanks, Joe.
All right. I think, as I mentioned earlier in my intro, that one of the bedrock requirements of a community health center is the requirement around patient board, the locally driven majority patient boards. And I'm just curious, from your perspective, how does this kind of root your work in the community and allow for space for innovation? So, Nancy, do you want to start, and then we'll go to Sonya?
Yeah, so about 72% of our board members are patients of the health center. And so, we hear the needs of our community. Through that board voice, we do a lot of expanded work in our care for the homeless. We have a street medicine team that's out working. Through our board, we've also expanded a lot of our geriatric excellence and care for older adults. Most recently, through the pandemic, every month you've got a nice cohort of your patients present at your board meeting to give advice and counsel on your innovation, give you feedback on the services they've received. So I think that helps a lot. I think also we ask ourselves the question all the time, who's not at the table? Who are we not taking care of in our community? And I think that drives a lot of our innovation when we see services needed that are brought to us from board members.
For me, when we talk about innovation and we talk about the requirement to have majority of your board members be patients, for us, it kind of builds in accountability and integrity and forces innovation. Many people like to watch that television show Undercover Boss, and I'd like to say I live that, every day. At any moment, a boss of mine can come in and begin to interact at the granular level, the service level, with our staff, with our programs. So when we are looking at need and we're talking about experiences and we're looking at data, if it doesn't match what that person experienced when they were in the office, then none of that data matters. They want to talk about what they've seen and what they know. And so what that does, it kind of bakes in this level of integrity, checks and balance, and just ultimate accountability that keeps us constantly having to meet current, future need, and to plug any holes or any gaps that anyone sees at any given time.
Yeah. I can imagine that having the undercover boss situation is interesting. I think it's just the previous panel was talking about kind of the social drivers of care, and health centers have been doing this for a long time, kind of thinking outside the four walls. I think it was originally founded on the philosophy of health involves more than just health care. And so early health centers were providing digging wells or providing a bus transportation, obviously writing prescriptions for food, as we heard about from Dr. Chen. I'm just wondering, so in your health center, how does that commitment to those social drivers of health continue to provide or manifest itself for your patients right now? Sonya, you want to start?
Sure. We operate from a model of whole health. And so taking into account all of those factors is part of that. And every 2 weeks, I onboard a new crew of staff members. And in that onboarding process, we look at the tapes that show the beginnings of this movement when the first health centers were started, what they looked like, what they included. So I'm always challenging those that are joining today that it's time for us to continue to evolve that model. It's not enough for us to take care of food, which we do. We provide boxes or those subscription services from farms where patients receive a box and it has fruits and vegetables. That's whatever is in season for that particular time coming directly to their homes. We don't assume they know what to do with those things that are in the boxes. So we make sure that we know the contents on any given week, and we put out YouTube cooking classes to make sure they know different things that they can do with the products that are in there, filled with medical education that tells them what it does and what it brings to their body and for their overall health and how it fits into their particular treatment plans. Back then, we've taken and we said, okay, well, there are prescriptions of things that are usually not part of what you would get from a doctor's office and would be part of your treatment plan. So we write prescriptions to parks in this DMV area. There is a wonderful, robust park system. And so we will have it integrated into our electronic health records, and we will write for them what park to go to and tell them what things to do there. And so kind of it remains baked in. When it comes to equity, there are all these images that show these people trying to look over a fence to watch a baseball game. And the one that I like the most was actually by an artist who put it out in 2015. And they have not just people standing on boxes, but they have those boxes standing at different levels. And the lowest level box also has the highest fence to try to see over. And it shows that the person has carved out a circle, and they're actually looking at the baseball game through the fence because that's the best that they can do. And that's the environment that we live in. There's a constant need to innovate, a constant need to have resilience and to have tenacity and to use whatever you have in front of you and take that to meet your needs. And so it's not even a choice that we can make. It's how we operate on every given day, and it's how we have to operate because we are not just responsible for completing visits. We're actually accountable at the board level, at the federal level, at the state level, at the county level, at the funders level, and we have many players within each of those boxes to actually deliver transformation for that particular person, whatever transformation that their particular need requires. So looking at the full spectrum of who they are and where they come from and what they have to work with is required to achieve those objectives.
Yeah. I love that imaging of the fences. Thank you. I was thinking about that because we onboard every other week, just like you do. And we go back to the roots of the community health center movement and why are we here and how are we serving? And I think it's also noteworthy that our data is submitted transparently to so many entities about the care we're providing. So we don't have the luxury of not sharing how we're doing on COVID vaccines, flu shots, mammograms, early entry into prenatal care. All that data is just really apparent. One of the things we do to kind of add to the thinking about that is the data collection that our patients complete on entry into our system around social determinants of health and the Prepare tool we use to collect that data. Historically, we used to have to talk to our patients about that, but now it's just part of a kiosk system. And I think it's been really amazing to me how the data has changed when I don't have to verbalize that I'm fearful of losing my housing, or I don't have to verbalize that someone's beating me up, that I get to just touch the kiosk screen and how that data comes into the electronic health visit. So as the provider, I then have the opportunity to gracefully come into some hard conversations with people about what their current reality might look like and how do we help them with what their priority is. I like the earlier conversation from another panel member about addressing what that person is there for today, because we do a lot of work around their own self-management goals. It may not be getting their A1C under 9. It may be about, I want to get home safely and know my children are home safely, and how do we help make that happen for them? So I think that priority piece is important. Also in our system, we've built a team called Health Builders, and their primary goal is to improve the health of our patient population and also to improve the health of our employees. We have about 1,700 employees, and we're a self-funded company. So, keeping them as healthy and tuned up as possible is important as well. But that Health Builder team offers everything from mindfulness to Tai Chi to weight loss to our pediatric or childhood obesity program, the MEND program, so that we're able to help families and help children and families, obviously longitudinally, hopefully to become healthier adults in line with what their community has to offer for them too. So a lot of that work is really community-based. The other thing we've built around social determinants of health is a closed loop referral system, so that within our system, if I have someone with food, even though we have food boxes in the health center, I may put a referral into the community food bank, which then loops around and comes back to us once that need is met. Because we have so many community partners, and I don't know if they're stable or if they're writing grants to make next week's payroll. So that closed loop referral allows us to know, yes, we got them rent assistance, they're not going to be evicted, or yes, we figured out a better transportation for them to get to the specialist, or yes, we're sending a navigator to go to the oncology appointment. So that closed loop referral in our EHR has been really an instrumental help to improve care.
That's great. I love that. Lifting up the need for partnerships at the local level, really to understand, where you can have leverage to really.
I just don't want to be in the housing business.
Right. There's you have so many other things going on right now. Just earlier we had a discussion around workforce, and it's hard to have any conversation in healthcare right now without talking about the workforce challenges. Just by background, NAC did a recent survey of health centers, and we saw that nearly 70% of health centers lost between 5 and 25% of their workforce over the last 6 months. And, a big piece of that was the ongoing stress of the pandemic, and obviously, the kind of increased salaries that we're seeing. As we think of short-term, long-term, medium-term solutions, there's a lot that has to happen. I'm just curious, how is that playing out for you and your local community, and ways and strategies that you're thinking about, dealing with it right now. So, Nancy, you want to start, and then go to Sonya?
Yeah, Sonya and I were actually talking about this over lunch a little bit too, just about some of the frontline staff, and particularly many parents who needed to stay home with their children during the pandemic, take care of loved ones. I would be out rounding. We have 13 different sites. I'd be out rounding, and it was amazing to me how many days when I would say, "How are you?" and the response would be about a sick family member or the loss of a family member to COVID and other complications. So I was amazed that we had so many employees that were at work with all the things going on in their lives. We lately have been really struggling with frontline, with medical assistants, licensed practical nurses, primarily. Those have been our two areas. And we also have been doing well on hiring registered nurses, which worries me because many of them are coming from tertiary care and saying, I can't do that anymore. I want to work in community. So I feel like kind of community poaching around that. But we've done a lot of workforce development, and we have a lot of strategies in place, and that we really believe in growing our own. So we serve as a tri-county regional AHEC, Area Health Education Center. So that gives us federal and state grant dollars to work on the pipeline. We start off building the health club, health career clubs, host the clubs in the high schools, in our urban and the rural communities. So we're starting the pipeline there with scholarships to get kids into Med Start in the summer, other immersion sort of experiences that are interested in healthcare. We also coordinate a lot of clinical rotations across discipline for medical students, nursing students, physical therapy, pharmacy, MPH, into our environments. And then we also are a continuing education arm. So we have a lot of opportunities to try to recruit and retain workforce there. We're a teaching health center. We do have AT Stills medical students on our campuses. We have a family medicine residency. And, the residents are closer to practice. I find the medical students are a little too far away. As you heard from an earlier panelist, they love every rotation they're in. And so our chances of capturing them into our workforce, particularly with debt, is challenging. But the residents more likely. We have a nurse practitioner residency program, so newly minted nurse practitioners can apply to our residency to do a 12-month residency right out of practice, giving them exposure to complicated patients, working side by side with experienced clinicians. And we train them for ourselves, and we train 2 of the cohorts to go out to rural community health centers. So we're also working on populating and helping the rural communities. Also along workforce, we work tightly with the community college. Right now, we're starting a cohort of 14 frontline employees who will become certified medical assistants. So they'll go through that 2-semester program, become certified, and they have a commitment to work for us for 2 years. So, a lot of growth in that way. We also do a lot around retention, Joe, around going back to the Institute of Medicine's Joy in the Workplace work. And how do we address the challenges of working with patients that not only have a lot of chronic disease and a lot of challenges, but also have community challenges, and keep our staff from burning out? So we've been doing a lot of things around planned leave, dedicated time, not seeing patients, and trying to build roles that not only have clinical practice, but also give people the opportunity for academic and research opportunities when we can build community-based research. I think the last thing I'd add, and then I'll stop talking, I promise, the last thing I would add is that we recently acquired an academic practice. And my main strategy was to have access to 24 family medicine residents with us for 3 years, hoping I can increase the pipeline of recruiting and hiring them. So I think that the residency is probably the best, and then in terms of growing all our other levels of staff, creating good job strategies so they kind of see their career through our eyes. So.
At CCI Health Services, my federally qualified health center, our patient population is about 70% Latino, 14% Black, 3% Asian, 5% white. And my staff mirrors those demographics, but skewed a little bit more toward Latino. And so for us, in terms of our workforce, we have a big draw in that people are able to care for those who look like them, but also the ability to work all day in your native language is a very powerful recruitment tool and a powerful retention tool. And so we'll have nurses and medical assistants and dental assistants who most of our patient population was not born in this country. They have come to this country. Similar with my workforce. And so for many of them, English is not their first language. And so taking the knowledge that they've gotten in school and being able to then apply it all day in the language that's most comfortable to them, to the population they most understand, is pretty powerful. What threatens that for us is in this area, we have lots of major hospital systems and private practices who know that if the person has worked for us, that they are first and foremost versed in high quality care. They know the evidence-based practice interventions to bring to bear. They are able to work with all populations. They are used to and ready and want to work hard. They're committed to making a difference. And so we almost become the job pipeline for the other major medical systems, because they're also will take a chance on somebody when they're an early career professional and will take them right out of school. And the other hospital systems know that. And so they'll let them work for us for about 5, 6 years or so. And then they just pluck. And we're happy for our staff members who will be able to earn salaries that we cannot pay them and that have career progressions that we cannot offer. So it's a double-edged sword. We are part of our mission. We're a learning institution similar to you. In El Rio, we have a planning grant right now to have our own teaching health center. And what I can tell you is that taking that on is hard work, and it's hard to find the partnerships, but we're committed to doing it, partly on behalf, as everything else that we do, of our patient population and our staff. Owning our own, controlling it and shaping it and making it what we need or what we want to see in the world is critically important to us, and we don't take that lightly. So we're taking on and we're doing the hard work. Those who are, we find that people get really excited when you start talking about putting together and having a community-owned residency program, but then there's not the help or the partnerships or the workers to help stand it up and to make it happen. So some of our challenges are around the burnout. We have worked every day in this pandemic, and we have worked inside offering in-person care the entire time. Throughout the entire pandemic, our telehealth population and service provision never reached above 6%. We were much more like the school systems, and that our households broke down when it came to trying to handle things other than living within their households. In the areas that I serve, it's not uncommon to have a 3-bedroom apartment house 3 to 5 families. Sometimes you'll have the master bedroom. We'll just have a line down the middle, and 2 different families will share that space. And so being at home and trying to have healthcare administered from home is not only not feasible, but it's not desired. We also had and saw a great deal of dominance within the households, where we'll have a male person in that house that controls everything, whether the internet gets turned on and can be used by everybody in the household, whether you can have a private conversation. And so what we learned is that our medical facilities were actually safe spaces, and people needed them and used them as such. And so we have a work environment that has all of those nuances baked in it, and that runs folks down. We are playing with 4-day work weeks, and not in the typical medical model where it's 10-hour days for 4 days and then a day off, but the true 4-day work week model that has you do deep work and work fully for 4 days and then have 3 consecutive days off where they're actually off. And providing that to a clinician and convincing them that it can be so is a difficult sell in some ways. But we're playing with that. The Teaching Health Center, once we launch it, 2 years is what we have to get that going, will help with our pipeline for clinicians. And then the others, it's really around increasing our pay levels such that $1 or $2, and that's usually all it's taking per hour for other systems to pull from us, so that we can retain them, so that they can continue to do the work that they want and also build their life and their households and advance their careers.
Really appreciate that. It seems like, what you talked about, obviously federal investment around teaching health centers. And we heard earlier that, that program has a cliff next year, and that needs continued funding. And so to think about starting it up with funding expiring, that would be daunting, right? And so, but then there's the career laddering, to show people that they have a career in the future there and they can move up. And then there's the grow your own, right? To tap into the community, and that may be.
Also,
Yeah.
I think also when you talk about the teaching health centers, the other piece about that funding, it does not get you to a break even on providing that. You mentioned about all the partnerships and the people you engage. Our investment in teaching health center has required us to underwrite the additional expenses for that. And I think that's part of the challenge in developing the residency programs across discipline, whether there are PharmD residency or NP, whatever residency programs we're working on, is that the grant funding doesn't cover the full cost. So, how do we improve and advocate for that as well, I think?
Yeah, I appreciate that. And what we're finding also, you heard earlier that they're only in 26 states. And so for me in the state of Maryland, we'll be the first community-owned residency program. And so the infrastructure is not in place for it. The state allows payments from the state to hospitals to administer residency programs, and it specifically says hospitals. And so we have to get that changed if we want to see any of those dollars. We don't have the relationships and the trail blazed. And so something that's been around for a long time, our health center has been around for 50 years, for example. This program has been around for a while, but it's new in our state and in our markets. And so it's almost as though you're starting from scratch, as though it never existed anywhere else.
Yeah, maybe transitioning for a second. So we obviously know that access to high quality primary care ensures effective chronic disease management and prevents hospitalizations and prevents more severe conditions. So just curious, what are some of the programs that you're seeing that maybe allow you to see around the edge? Sonya, I would love to hear. We were talking a little bit about a program that you have around prenatal care and the importance of that. So it's an innovation that you're working on right now?
The majority of our patients are in those childbearing years, 18 to 40, 45. And so we do quite a bit in women's health, but also quite a bit in prenatal and making sure that we start the interventions of whole health from the very beginning, from inception to delivery, and then care for them after that. And so we do employ the centering pregnancy and centering parenting models. We have found both in terms of concrete data and anecdotally that having those shared or group visits around gestation and around prenatal and around delivery is huge. We are a huge integrator of our WIC services into our primary care, and so chest feeding is a huge part of what we teach and what we promote, so much so that as we've gone through as a country this latest baby formula shortage, and I guess it's actually global and not even just in our country, it hasn't hit my population as much. 90% of our delivering patients chest feed upon delivery. We teach it as they are going through their prenatal care. We embed a breastfeeding peer counselor in the hospital so that when they deliver, that's one of the first visitors that they have, and they're working with them and working with the baby right there and then before they even go home, and then support continues after that. We make sure that we have our Reach Out and Read program, that it begins not after the baby comes, but also during that prenatal period. And we begin to talk about the importance of reading, and we know that the difference that makes alone in terms of somebody's health and as one of those social determinants of health. And so for us, it's taking the needs of that population, caring for their bodies, of course, but also recognizing that there's a mental health component to when you're carrying and when you deliver, and what might happen biochemically to your body after you deliver. So we have our behavioral health specialists and consultants who are part of that prenatal education process, and so that they get seen by the dentist, they get seen by the therapist, they get seen by all of our additional services, the nutritionists and all those folks, so that when they deliver, all of those needs have been provided for and ramped up, and they're aware to be aware of them and to watch out for them.
That's great. I know we also are a centering shop too. And we have an integrated model between OBGYN physicians and certified nurse midwives. So they also do home visits after the birth. And we also have a lactation educator, which has been fabulous. I really have been pleased. We've only had it over a couple of years. So I guess I'll go to the other continuum, the other end of the life cycle. We'll talk about some of the work that we do with older adults. So we have our team-based model, as I mentioned before, is interdisciplinary, but we've started adding other specialists and disciplines to that model just based on the needs of our older adults. So, some of our patients who are very fragile, who we try to minimize readmissions and hospitalizations and skilled nursing stays and things like that. So we've added physical therapy to our scope of service. We started looking across our system, and we were generating about 125 referrals for some type of therapy weekly, and not being able to get access to care for our patients. So we just employed them. And for the physical therapist, this is great because now we have other team members laying their eyes upon some of our most high-risk patients more frequently and having the ability to work on strength training, of course, in our older adult population. So physical therapy has been a hit in terms of chronic disease management for us. But I really liked our very first physical therapist told me that in all her years of practice, she'd always been an outpatient provider. And she said it was just amazing to her to see a patient and be able to have full look into that patient's record, to be able to say, looks like you're overdue for your mammogram, looks like you haven't had a flu shot. And in all her years as a physical therapist, she never had vision into those other pieces of care. So it was just a really clear illustration of what having an integrated record can do and not having to work around the traditional healthcare system to hunt for data, whether it's lab results, colonoscopies, or whatever it might be. So, adding that team member has been really important. Our RN care coordination team is both centralized and decentralized. At the centralized level, every day they're pulling from the HIE all of our patients who've been admitted or discharged so that phone calls can be made to say, how are you doing at home with your newborn? Do you have your follow-up appointment? Do you have your walker? Is someone home? Food in the fridge? Do you need us to deliver your meds and going over med reconciliation? So that centralized piece. And then each of the locations have a team of RN care coordinators who manage a panel of high-risk patients in concert with the provider so that they can do the chronic care visits and bill Medicare for those, so they can anticipate gaps in care and try to avoid unnecessary use of tertiary care. So those folks, and then there's a 24/7 telephone care team that takes all the calls from our patients, whatever their needs may be, whether it be questions around education, how do I get into the portal, how do I need a virtual visit? So I think for us, the investment in those other disciplines on our team has been really helpful. We've been really fortunate to be able to hire some psychiatry, geriatric psychiatrists. We just also started a child psychiatrist so that our pediatricians, our adult providers have access to do a warm handoff when people are willing to have that intervention, when people are in our site and they don't escape before we have to track them down, but we're able to build those pathways around care. So I think the question around innovation for us now is, should I hire some more folks that are specialists? How much of that specialty pathway of care should we try to manage the best we can? We have, for example, we have a part-time pulmonologist now. All of our COPD, our respiratory patients, get worked up there if need be. And that, internal piece into our system has been very useful for us as well. Yep.
Yeah. So maybe last question. It's hard to have a conversation around innovation without thinking about the COVID element to this, right? And how everybody had to kind of transition quickly. Obviously, telehealth is a piece of that, but obviously we've also seen an increase in the mental health and needs across the country. And because of isolation, health centers have had the physical health side with providing vaccinations and testing. But I'm just curious, around the behavioral health needs that you've seen since both of you are providing integrated behavioral health. So Nancy, maybe you start and then Sonya.
Yeah, and our entree into behavioral health was probably about 12 years ago with just simply attaching a licensed counselor to each of our primary care teams. So the warm handoff I mentioned earlier, it could happen easily. I'm finishing a visit with a patient who suddenly says, oh, by the way, I just learned my mother's been diagnosed with Alzheimer's. I don't know how we're going to deal with this. And my ability to say, let me introduce you to Jim. He's part of my team. He can probably help you figure out some coping mechanisms, help you kind of plan what resources are available. So we've always done that in screening for depression. But about 4 years ago, we started really building what we call specialty behavioral health with our therapists, our psychiatrists, our intake case managers, our substance abuse treatment program. We do Suboxone and Vivitrol, and are also starting to do intakes in the home for that population. And the demand, every day our behavioral health team huddles in the morning just to triage the calls that come in from discharging hospitals to establish behavioral health care for our patients. Some of our managed care organizations in the Medicaid space have now started really looking at, okay, you're taking care of this Medicaid member on the primary care, but they're getting their behavioral health out here. Does that make sense? Patient choice, of course, but in communicating, you can now get your psychiatrist and your therapy where you're getting your primary care has been a real winner for members. Once again, allowing that care to be highly synchronized and highly integrated for them. The demand is still more than we can. Back to your workforce question, we've been fairly successful with psychiatry. Therapists are where we're really having challenges in recruiting. But, the demand in our community is high for all patients, self-pay patients, people with a commercial insurance, everyone.
Well, I'm a licensed clinical psychologist, so we have mental health and behavioral health baked throughout the entire organization. We are a trauma-informed practice. From the time somebody comes in the door, we are making sure that they are physically safe and they are psychologically safe. We're paying attention to the words that we use. We look at our delivery of service and believe that there's some component that operates in all of it. In COVID, there have been some additional demands, and so I actually do neuropsychological and psychoeducational testing because so many of our students are behind or experiencing learning challenges, or things are happening and school systems and teachers and parents and families don't know what to do and don't know what's going on. Is it cognitive? Is it emotional? Is it a combination? Somebody needs to know what to do next. We are a huge provider of service in the refugee health program and have been, and we have had a 127% increase, 2,000 more patients of Afghanis who are here in this country through that program. And so the demand of that has meant I have started to do the intakes so that we can find out from the referrals from that population. And as an organization, we've had to add our depth of service around trauma-based disorders. So we now offer eye movement desensitization and reprocessing, EMDR treatment, because it's evidence-based to really go for those who have deeply rooted and seated PTSD, because that's what we're finding. We have a large degree of our population who come to this country non-assisted through a program, but through their own means. And that journey and what they face once they get here is filled with pretty intense trauma. So we've always had a lot of trauma in our population, but it has really significantly increased as the violence at home has ratcheted up and in neighborhoods, and as the folks that were doing okay before, 2 years into this, the answer to how are you doing or what's going on is, I'm not okay. And that's at all levels. That's not even people just living on the margin. A lot of folks are not okay. And so we assume that there's some degree of breakdown, may not be to diagnosis level, but in psychology, we say anything that impacts your ability to love and to work and to play effectively might need to be addressed in some way. And in the people that we're seeing, there's some degree of breakdown in their ability to love, work, play, and exist effectively.
Well, thank you so much for your contributions to this broader conversation around primary care and innovation. So I think we're going to transition now to a panel around the employer market. And I should have brought my program to introduce the panel. But thank you very much, and I look forward to hearing the rest of the conversation today.
Thank you.
Thank you.
All right.